describe the same. Now, one important thing which is invariably asked is, sir, when I ask start ACE inhibitors ARBs, there is a problem of high creatinine and there is a problem of hyperkalemia. So please understand, this is one of the very good slide of showing you the monitoring of serum creatinine potassium levels. Now, every patient who's on ACE inhibitor ARB should be monitored for serum creatinine and potassium within 2 weeks of starting. Now, you can have three effects. You can have normal kalemia with less than 30% increase in serum creatinine. We can gradually increase the dose in such patients. Patient can have hyperkalemia. What is important is review the current drugs. Is the patient on any drug which is further causing hyperkalemia? Consider the use of diuretics, soda bicarb, or exchange. Don't stop ACE inhibitors just because the patient has hyperkalemia. Give him a low dose of diuretics. It will decrease the diet in such a way that his potassium levels are. But if the patient has more than 30% increase in creatinine, then of course we have to review for causes of AKI. We have to correct volume depletion. We have to reassess concomitant medication, and we have to consider whether this patient has a bilateral renal artery stenosis or not. Then we should reduce or stop the ACE inhibitors therapies. In such a situation, we should not stop. We should in fact continue to increase. Now, as I said, this was the recent study which was published in 2015 to talk about effect of finerenone on albuminuria in patients with diabetic nephropathy, and this was done in almost more than 1,000 patients. The hyperkalemia was less with this drug, and this drug showed that giving finerenone, that is mineralocorticoid receptor blockers, can help you prevent the progression of CKD. Second is, a lot of things have been talked about glycemic control. The problem of HbA1c in CKD is manifold. There can be falsely elevated HbA1c because of the hemoglobin, because of carbamylation, because of uremia, because of metabolic acidosis. On the other hand, falsely normalized HbA1c can be because of shortened lifespan of RBCs, accelerated erythropoiesis, and frequent transfusions. So we need to take it with a pinch of salt. In CKD, we need to be careful and have a personalized approach. What is important to us to have a strategy? Can we target less than 6.1%? Yes, in a patient whose microvascular complications are not there, whose severity of CKD is mild, who does not have comorbidities, who has a long-term life expectancy, and who has hypoglycemia awareness present. So these are the patients where we should target for strict control. On the other hand, a patient with CKD5, a patient has severe hypoglycemia, a patient does not have an awareness, a patient's propensity to treatment to cause hypoglycemia is high, there the target has to be lower. So every patient has to be individualized. And these are some of the newer molecules or newer factors which has come. How to multi-dimensionalize the predictors. Now we know about age, HbA1c and this. Now we have certain newer inflammatory markers which have come up. We have also markers for kidney fibrosis. We have marker for kidney injury, and we have marker for advanced glycogen pathways. Of course, these are the markers which are still experimental, but very fast you're going to have a computerized based precision model which will tell you about what drug need to be given to such patients. As I said, glycemic management should consist of lifestyle. We all agree the first drug of choice has to be metformin, but after that, the recommendations have clearly given a second line drug as a sodium glucose transporter inhibitor, SGLT2 inhibitors, and if the blood sugar are not controlled, then GLP-1. Of course, in Indian such sort of patients, we need to understand that these drugs are a bit costlier. We need to individualize the treatment. EGFR more than 30 ml, we can continue with all these drugs. Of course, the dose of metformin needs to be reduced, and we should ensure that patients are not vitamin D. A word about SGLT2 inhibitors. Apart from its anti-hyperglycemic effect, there are significant amount of changes which it brings about by decreasing the blood pressure, by inhibition of tubuloglomerular feedback, by proximal tubule decreased sodium reabsorption, by decreasing tubular inflammation. It causes a global kidney protection. Number of studies have shown a kidney outcome which are much better with SGLT2 inhibitors. It not only decreases the afferent arterial constriction, it normalizes GFR, so it causes some hemodynamic changes, decreases the global GFR, resulting in significant amount of cardiovascular and kidney benefits. And there are certain days which we need to withhold SGLT2, especially when your patient is very critically ill. is undergoing surgery, is fasting, but definitely we can continue SGLT2 inhibitors still around GFR of 30, and we need to be understanding that this is backed by a strong evidence of Credence trial, which has very clearly shown that superiority of it to placebo and in CKD patients, and also this drug may be considered routinely among similar patients of CKD. And another important molecule, but very costly, I do not personally prefer it, but those who can afford, is the GLP-1 receptor agonist. They are, of course, short acting and long acting. We have once a week also drugs available. They have also been found to be, one of the key drugs which can not only control blood sugar, but also prevent the progression of chronic disease, which is what my topic was today. And DP4 inhibitors are also kidney neutral. They can be given even in the presence of low GFR, but the dose needs to be reduced. And this was the editorial written in 2020, and they have clearly shown that GLP-1 receptor agonist has commenced and will answer question whether drugs will be effective to reduce diabetic kidney disease or not.